It's really an honor to share the stage with all these great speakers. This has been a really great conference, and I want to acknowledge Tom Bird. I had the distinct honor of working side by side for many years with Dr. Bird, and if I have any infamy, it's that. I go to meetings and say, hey, I'm Greg Carter, and they go, oh, you worked with Tom Bird. Which I say yes. Okay, how do you advance the slides? Whoops. Okay, what am I doing here? I will just go with that. Okay, so this is a paper actually that I did with Dr. Bird. And I think it was actually the first paper, really a large paper. There have been a couple of case reports, but as Dr. Bird alluded to, anybody that works with CMT patients will note that they complain of a lot of pain, justifiably so. And I remember talking to Dr. Bird. I said, Tom, when I was in training, I said CMT was painless. So why are all these people telling me they have pain? It's not painless. Actually, I think this study, which was 670 some patients, I believe, the vast majority, like 77%, complained of some type of pain. Okay, what am I doing wrong here? I'm trying to advance the slide and nothing's happening. Do I point it at something? The arrow on the right. Oh, on the right. No? Here, show me. Okay, I feel better. Now she can't do it.
Can you just let Christopher know when you're ready?
Sure, next, thank you. All right, so this is, I mentioned, 617 patients. So 71% reported pain. Again, as Dr. Bird alluded to, it's a combination of two types of pain, musculoskeletal and neuropathic. We'll talk more about that. But low back pain is probably mechanical or musculoskeletal pain. And as Dr. Peffer had some great videos, you see people with CMT have abnormal gait biomechanics, probably stemming from their foot abnormalities on up the chain, but because everything's connected, foot bone's connected to the ankle bone like the old song goes, and it's true. So you have an abnormal kinetic chain starting at the feet going all the way up through the spine. Knees, ankles, toes, and feet not unexpectedly. Next slide, please. 39% had reported interruption of activities of daily living. 38% used non-narcotic pain medication, 23% used an actual controlled substance to control pain, and the descriptors for CMT-related pain were quite severe and comparable to people with something called complex regional pain syndrome, which is a very bad disorder of the nervous system that causes pain, diabetic neuropathy, and peripheral nerve injury. So that was the pain reported by CMT patients was along those same lines. And the descriptors hot, dull, and deep were among the most common descriptors. Next slide, please. So that was 20-some years ago. There's now a number of pain studies that validate what we found many years ago. So this is a study in children. It turns out that children also report similar problems with pain. Unfortunately, children with CMT. Next slide, please. And there's a couple of more recent studies that also confirm our initial findings. Next slide, please. So I think the types of pain that people with CMT have can be tricky to treat. So neuropathic pain is pain that originates directly from nerves that are abnormal. That could be, as I mentioned, from a nerve injury, like a gunshot wound or a traumatic from a car accident or something, or it can be from a disease like diabetes. Diabetes causes a painful neuropathy, and most of the problems in diabetes are demyelinating. Most but not all forms of CMT have demyelination. And so the nerve loses its coating. And one of the theories of neuropathic pain in that model, of demyelinating model, is that you get ectopic foci of nerve pulses. So the nerves kind of fire on their own because the coating of the nerve has been stripped away. And those little foci of electrical impulses generate pain. Mechanical pain is really related to abnormal biomechanics. So the spine bears a heavier load because there's weakness in the core muscles and the hip and flexors. And then certainly down in the knee and the foot, you have very abnormal biomechanics. And that, again, goes right up the chain. Pain in CMT would typically be considered chronic. So we're in kind of a new world in terms of chronic pain. I've managed a lot of patients with CMT over the years and have used opioids, but now opioids are kind of taking a fall, as it were, and they certainly are dangerous and need to be used cautiously. But chronic pain is pain that is treated very differently from acute pain. If you drop a hammer on your toe, that would probably hurt really bad with CMT, but it would hurt anybody. And that's acute pain caused by usually a trauma, and then you might have tissue swelling and some type of reactive changes in the nerves, but then that would go away. Chronic pain is pain that lasts longer than 3 months, and that's the type of pain that people with CMT have. Next slide, please. So there's actually the definition of chronic pain: an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And the damage in CMT would be from the nerve abnormalities and then the mechanical problems that really relate to osteoarthritis. And since we've talked history, great talk in history, Tom, I've come to love history now as an older guy. I hated it when I was in school. But Charcot also described the Charcot Joint. He actually initially described it, I believe, in tabes dorsalis, which is caused by a syphilitic infection in the spine, which destroys the posterior columns in the spinal cord, and the people would lose proprioception and deep sensory perception in the joints. So they'd walk abnormally and they couldn't feel that they were destroying their joint, that causing arthritis. And that's kind of the same thing that happens in Charcot-Marie-Tooth disease. You have sort of abnormal feedback to the brain about what's going on in your ankle, and like Dr. Pfeffer was alluding to as well. So you can continue to walk on an abnormal joint and just wear it out, literally. And anybody that's worked with CMT over the years, I've seen some incredibly abnormal ankles, very deformed. So that's called a Charcot joint, sometimes called a neuropathic joint as well, and it's the same guy. Next slide, please. So I want to talk about things that you all can do to help manage pain in CMT. So a lot of this is common sense, although over the years, I mean, I'm surprised sometimes people don't take care of themselves and then come to a doctor and say, I'm having these problems, and first thing you might say, well, is we need to lose 50 pounds or 100 pounds. So you want to optimize your health. And that really, for CMT, it's very important to maintain normal body weight. And that's kind of a no-brainer, right? Because you have weakness in the muscles that support your musculoskeletal system, and so you don't want to add any weight. And if you're 30 pounds overweight, you know, you're basically carrying a 30-pound backpack around all the time. Don't smoke. And really, you want to minimize alcohol intake. I enjoy a beer, but alcohol is neurotoxic. If you drink more than an ounce or two a day, you probably are contributing at least a little bit to nerve damage. I was crushed by a recent study, I guess it showed no health benefits apparently of alcohol. I always kind of justified my nightly beer by saying, well, I'm helping myself here, but I guess that got tossed out. You want to exercise. Exercise can improve cardiovascular function, and the heart is not affected in CMT. So if you do endurance exercise, you're going to increase cardiac output. Your heart's going to pump more efficiently. You're going to get more blood out to the muscles and a more oxygenated blood. And that's going to help with endurance, because fatigue is a very common symptom in CMT as well. You want to avoid a sedentary lifestyle, even though you guys have to fight it more than people without CMT, but you got to fight it. You got to maintain activity. So exercises like walking, swimming, biking, and then body weight strength training. By body weight strength training, I mean avoiding like dumbbells and using your body supported weight. You have to use common sense here. Next slide. So I'll jump down to the last bullet point. You want to avoid obviously putting an undue strain on your joints. So I have had patients over the years, typically younger males, that want to exercise their way out of CMT, and that can cause more problems, especially if you're doing dumbbells or barbells and you have weakness around the wrist joints. I had one guy that really damaged his wrist badly from trying to do a bench press with a massive weight. So some of the new machines in gyms totally use body weight. So you're like using a counter lever to lift your own weight. The Cybex machines are very good too. They have a smooth isokinetic weightlifting, which means the load that you're bearing is the same throughout the arc of the exercise, as opposed to a free weight where you sort of have to go push it real hard and then it gets easier. And some of the old weight machines are like that too. That's not as good. So if you have access to machines that have the same force as you go through the arc of motion, that's the best. You really want to emphasize your core strength. I mean, everybody should be doing that, but that's particularly important in CMT. Remember, I said low back pain was one of the more common, if not the most common reported pain. And that's really because of weakness, and weakness in the core muscles, hip and pelvic girdle muscles. And then you should try to really, you don't want to exercise to exhaustion, which sometimes people do because they want to do everything, try to work through the disease. You have to accept that you have this disease and learn to live with it. So do exercise that helps you. Don't overdo it, and try to do exercise that's oriented towards improving your functional deficits. Next slide, please. So certainly there are physical therapy and occupational therapy modalities, and I'm sure all of you have seen PTs and OTs. And they can help if you're starting an exercise program. I would recommend that you see a PT or OT that knows CMT. Now that's key, because there's a lot of trainers out there too, and some of them are quite good, but if they don't know about CMT, they might give you bad advice and you could end up hurting yourself. So make sure you're seeing a professional that knows what CMT is. We had wonderful talks on bracing, so I'll leave that be, but appropriate bracing, well-fitting bracing can help with pain. It'll support the joint and improve function, and by supporting the joint, you're going to minimize the chance that you could cause further joint damage. Medications we'll talk more about, and then regular routine medical follow-up is super important for you guys. It's important for everybody, but make sure you're seeing a physician, and you should all be seeing somebody that knows about CMT. That's not that easy. I realize that. And then if you have other comorbidities like depression and stress, manage it, because stress and depression go hand in hand with pain, and they both make pain worse. And that's been very well demonstrated. So when I talk to some of my pain patients, maybe I'll administer a depression scale, and they say, why are you, I'm not depressed. Well, let's just do this, because it's been very well, Mark Sullivan at UW has shown really that there's, in patients without CMT, just able-bodied people, it's almost hand in hand. In fact, some people would argue maybe the depression comes on and causes the pain. And that's in a non-CMT population, but you can't separate out chronic pain, depression, and stress. And it doesn't even matter what the source or the cause of the pain is. And great talk on breathing, and you want to correct non-restorative sleep patterns. And Ashraf said that, he mentioned the needle EMG of the diaphragm. I'll just tell you quickly that I had a pulmonologist years ago, when I first started out, referred me a CMT patient. He wanted a phrenic nerve conduction and needle EMG of the diaphragm. And the very first pass I took with the needle doing the EMG, I dropped the guy's lung. So it's very hard. The diaphragm's moving. It's a flat, skinny muscle, and it's not easy to hit. But you want to, if you're having breathing problems and you're having non-restorative sleep, address that, because that does impact pain. And abnormal sleep is another thing that a lot of folks in the pain world, researchers in the pain world, it's very hard to separate out. People with chronic pain have problems with non-restorative sleep. People with non-restorative sleep often develop chronic pain. So it's kind of like depression, sleep, pain. That's sort of the holy trinity. Next slide, please. Now, it's harder for people with impaired mobility to exercise. I get that. So take everything I'm saying with a grain of salt, and that's why you may need a coach, but that coach has to be knowledgeable about CMT. It's also easier for you folks to gain weight, but those are bad things. There's something called metabolic syndrome, which has been studied in CMT and other neuromuscular disorders. And it's associated with increased blood pressure, increased blood sugar, and elevated lipids. So it's kind of a pre-diabetic, pre-hypertensive state that you're at higher risk for. And exercise diminishes cardiovascular risk over the long haul, so it's very important to try to do that. If you're having trouble losing weight, see a dietitian or a nutritionist. Next slide, please. Osteoporosis. So I mentioned the Charcot joint, the neuropathic joint. Well, that can be made 10 times worse if you have osteoporosis, which is thin bones. And you all are at risk for osteoporosis because you have abnormal gait biomechanics, lesser weight bearing, lesser muscular forces across the bones. Astronauts go into space, they all come back with the signs of osteoporosis or osteopenia, which kind of precedes osteoporosis. So if you're a postmenopausal female, even more risk. But even men with CMT can get osteoporosis. So you want to get some sunshine. That's not so easy to do in Seattle. Vitamin D and calcium. Make sure you get your bone density monitored, and then medications like Didronel or some of the bisphosphonates, allandrate, there's a bunch of them now, to help improve your bone density and make sure it's monitored. Because the combination of osteoarthritis, Charcot joint, osteoporosis was very bad. Next slide, please. This is also kind of a no-brainer, but if you sprain your ankle, and Dr. Pfeffer alluded to that, get that addressed immediately. So any type of musculoskeletal injury in CMT is a big deal. It's automatically a big deal. Some people sprain their ankle, they might run down to Walgreens, get an ACE wrap, and just kind of blow it off. You get a sprained ankle, you get in and see your healthcare provider, and probably see an orthopedic surgeon. Get it in a brace, whatever needs to be done, but don't blow it off. Because you've already got some problems with laxity and abnormalities in the joint, and you injure a ligament in there and you don't treat it properly, it's gonna, I forgot what he said, make all big problems start small. That's a good example of it. So sprained ankle can turn into a huge problem. It also can trigger inflammation, which is not good. And you start an inflammatory process in a joint that can worsen destruction because it releases chemicals and cytokines, prostaglandins, things can get out of hand, and you end up with more joint damage. Next slide, please. So we'll take a little turn here and talk specifically about neuropathic pain. So a lot of the pain in CMT is probably caused by all the stuff we just talked about, joint inflammation, arthritis, degenerative changes in the joint, because you're walking funny, kind of running the engine not quite in alignment. But there's also nerve damage. That's the hallmark of CMT. And the damaged nerves can generate pain. Don't feel like you're being a weenie or something if you're complaining of pain, because neuropathic pain is theoretically described as the worst type of pain, like a toothache. But the good news is that it is treatable, and there are many effective medications. Next slide, please. So anti-inflammatories can help, and they can certainly help with musculoskeletal pain. The problem with anti-inflammatories, I'm talking about Motrin, Advil, that kind of stuff, is you cannot take them long-term. So I want to say that again. You cannot take meds like Motrin or Aleve, Naproxen, any of those long-term, because you'll end up damaging your organs, kidneys particularly, stomach. The reason I have a hoarse voice is because I have horrible reflux. I used to take a lot of anti-inflammatories. Now I can't do that. But you will damage your organs. So they work in the short term, not good in the long term. So what can become the hallmark of this of treating neuropathic pain are the anti-epileptics, and probably a lot of you have tried gabapentin or Neurontin or pregabalin or Lyrica. Those are very effective medications for nerve pain, and they're generally well tolerated. They do need monitoring. The antidepressants, so you're saying, okay, he's preaching on depression again. Well, it turns out the antidepressants work very well for neuropathic pain, and they work even in an animal model where the brain is if you put a tourniquet on a hind limb of a rat and infuse, I know it's been done with Prozac or fluoxetine, you infuse that into the hind limb and it can't get to the brain, and do tests that monitor pain, they're improved. So fluoxetine probably affects what they call a fast sodium channel in the nerve, stabilizes the nerve a little bit, and helps with neuropathic pain. So even if you don't let the chemical get into the brain, it helps with peripheral neuropathic pain. But better than what the Prozac would be, a serotonin reuptake inhibitor, but the better drugs are the serotonin norepinephrine reuptake inhibitors, SNRIs. A new one would be a Cymbalta, or dualoxetine is the generic name. An older one would be Effexor or venlafaxine. So if you're having problems with nerve pain, a combination like Neurontin, gabapentin, and Cymbalta, or duloxetine, that would be a good combination. Any of those that I mentioned. Some of the older antidepressants called tricyclic antidepressants also help very well with nerve pain, and they're actually the best studied. An example of that would be nortriptyline, and maybe some of you have taken amitriptyline. The trick with amitriptyline, though, is it has a lot of anticholinergic side effects, so it's going to give you a dry mouth, and it's also been associated with weight gain. So if you're on amitriptyline, ask your healthcare provider to switch you to nortriptyline. You get all the benefits, less side effects. Opioids. It's hard to talk about opioids these days. It's been through a sort of a whole change in process. I think opioids do have a role in chronic pain management. They just have to be monitored. And a lot of what got us into trouble with the opioid crisis were people weren't being monitored, they were being overprescribed, the drug companies were making physicians believe that this was safe. I was a pain fellow at the University of Washington back in the early 90s, and we were taught that there's no ceiling dose for opioids. You could just elevate the dose until the pain goes away. It turns out that was not correct. And that very thing is what led me to get interested in cannabis. Next slide, please. I think I already mentioned that. Oh yeah, acetaminophen is another one that you have to be careful with too. If you take more than 3 grams daily, you can end up with liver toxicity. So anti-inflammatory is kidney, Tylenol is liver, and Kenny Easley, the old Seattle Seahawks linebacker, he ended up on dialysis from taking too much Motrin. Next slide, please. So the last bullet point there is important. So I think the anti-epileptics and the antidepressants are good, but people with CMT may complain of muscle spasm or pain in their muscle, or the back's hurting, and the healthcare provider gives you a muscle relaxer. Well, most muscle relaxers don't relax muscle. In fact, just do this as an exercise if you want. You take a drug like Scalaxin or methocarbamol, any of those, and you go to Google it, look up the mechanism of action, and oftentimes the first sentence will say, centrally acting, exact mechanism not known. And I'm not, just do it if you don't believe me. So as a physician, I don't really like prescribing medication where the mechanism of action is not known. All those muscle relaxers generally are sedative hypnotics. So you feel kind of mellow and relaxed as you slide into your lounge chair. Well, remember I told you want to stay active and moving around, so you don't want to take muscle relaxers. They're just going to deactivate you, which is ultimately going to make your pain worse. It's going to make your health worse. And they don't even relax muscle. So the only time a muscle relaxer something like Flexeril can help with sleep, but again, let your physician sort that out for you. But I would say in general, avoid muscle relaxers. Next slide, please. Next slide, please. If you are on the last bullet point there, if you are on an antidepressant and you're having sexual side effects like anorgasmia or inability to climax, that happens actually. You can alleviate some of those side effects with a small dose of bupropion. So make sure you discuss that. Don't accept that as a side effect. Life is hard enough if you can't enjoy sex. That's a bad thing, right? So take the bupropion. I wasn't joking, right? But next slide, please. I think I don't want to spend a lot of time on opioids. I'm going to talk about cannabis next, which I think is a better option. But opioids are dangerous, and some of the newer synthetic opioids are extremely powerful. So fentanyl has caused a lot of overdose deaths. And a lot of the deaths, at least in Washington State, I'm privy to some of that information because I'm on a panel with the state. A lot of the opioid overdose deaths in Washington State are associated with also muscle relaxers and specifically benzodiazepines. So the combination of opioids with benzodiazepines were really bad. You go to sleep, you don't wake up, and if you have sleep disordered breathing too, then that worsens the thing. So that's not to say that they might have a role for you, but they have to be used cautiously, and I would make sure that you don't get on an escalating dose. Because interestingly enough, with most opioids, as you get on a higher dose, you don't get better pain relief, you just start getting more side effects. Constipation is another side effect too. And that's an area of CMT that actually needs further investigation, is the GI tract. In my experience, a lot of people with CMT have GI problems. I tried to get funding for that years ago and couldn't do it, so I sort of gave up. But I still think that's an area that needs to be investigated. Next slide, please. So, cannabis. So my career has been spent entirely in taking care of people with neuromuscular disorders, including CMT, but also ALS. And I had an ALS patient years ago tell me that he was using cannabis, and this was back right when it became legal for medical purposes in Washington State, which was 1997. And full disclosure, I went to college in the 70s in California, so yes, I used cannabis. But, I'd forgotten about it and whatnot. You don't really learn about it in medical school. Well, this guy was adamant that it was helping him. So I started doing some research, and it turns out there's massive, we can't cover it today, that's for sure, massive amounts of research on cannabis, most of it done in animals, but and we do know a lot about cannabis. And then going back to history, like Dr. Bird here, these are examples of pharmaceutical-based cannabis medicines that were available before the whole reefer madness thing in the late 30s. And I don't want to get off track too far, but that was really driven by politics and maybe racism. So in fact, the AMA fought back against that. So doctors tried to keep cannabis on the market. So there's a cannabis indica strain there. And you probably can't see that, but what it says on there is Nerve Tonic number 5. I love that. You've heard of Love Potion number 9. This is Nerve Tonic number 5. But in the age of evidence-based medicine, where we can't do anything unless there's randomized trials showing it, back here in the 20s, they knew that it worked for nerve pain, interestingly enough. So next slide, please. So what would an ideal drug to manage pain in CMT look like? Well, it certainly have to have analgesic properties, maybe some antispasticity properties, muscle spasm, that type of stuff. Antioxidants, we know as nerves undergo degeneration, they create free radicals, which is an unpaired oxygen, O-. And the problem with O- is the body doesn't like charged particles like that, so it'll glom onto a protein or something and then denature or destroy the function of that protein. And that's theoretically one of the ways we age, is by building up more free radicals in our body. Anti-inflammatory properties as well, and you talk about joint inflammation and arthritic stuff. Well, cannabis would appear to have activities in all of those areas. So a single set of compounds of cannabinoids has activity in all of those areas, and remarkably little toxicity, it turns out. Next slide. So what was really a game changer in the whole use of cannabis as medicine once again was the discovery of the endocannabinoid system. So with opioids, we have our internal endorphin system, things called mu receptors. So opioids that you take bind to the same receptors that your endorphins do. And so it's drugs that are receptor-based, that sort of a lock and key thing. Those are better drugs because we know how they work, but there's a described mechanism of action. That's a lot better than a muscle relaxer that just kind of puts you to sleep or just sedates you in generally. So the cannabinoids bind to two types of receptors, CB1 receptors in the brain and the upper parts of the spinal cord, and then CB2 receptors in the peripheral nerves, gut, bone, musculoskeletal system, cardiac system. So there are few receptors, cannabinoid receptors in the brainstem. So one of the things that really makes opioids dangerous is they suppress breathing. And you just had a great talk on breathing in CMT. You don't want to suppress breathing in any situation, but certainly in someone with a neuromuscular disorder. So cannabis and cannabinoids will not do that. And they also will not cause constipation in the gut. In fact, there's some evidence that they help people with Crohn's disease. Next slide, please. So the cannabinoids, of which there are probably over 100 in the natural plants, control pain, appetite, mood, sleep, gut motility, muscle coordination, short-term memory, suppress inflammation, don't cause respiratory suppression, and have a low toxicity if used properly. Everybody's heard this, it's impossible to overdose on cannabis. That's technically true, so there's no lethal dose 50 for cannabis. The trick is, like I said, there's over 100 different cannabinoids. The main intoxicating cannabinoid is THC, and we can actually prescribe that. It's a Schedule III drug, so I could literally phone in a prescription for that. Everybody's heard of CBD or cannabidiol, and there's another one called cannabinol, which is an anti-epileptic. And now there's a new drug called Epidiolex, which is used to treat a rare seizure disorder. But cannabis can suppress seizures. And those two cannabinoids are not intoxicating at all. There's a lot they need to study on them, but THC is the best studied, and that's the one that makes you intoxicated. But a lot of strains of cannabis now have very low THC, and theoretically are not or less intoxicating. Next slide. So those are some of the other ones. There's also some things called terpenoids in cannabis, which are sort of related to cannabinoids, and they may also have some of the therapeutic effect. Cannabinoids are actually not that unique in the plant world. There's something called flavonoids. You find those in dark chocolate, for example. And flavonoids actually bind cannabinoid receptors in the brain. So you hear people saying they get high eating dark chocolate. That's actually true. If you eat enough dark chocolate, you activate your cannabinoid receptors. There's also caffeine in chocolate too, so it's kind of a double effect. But that's true. Next slide, please. So if you're going to use, now here's complete disclosure here. You know, Washington State is like, you know, Berkeley in the 60s. I mean, I'm speaking as a physician that practices in Washington State. Now it's recreational. I mean, you can get cannabis anywhere. If you're from wherever, you know, I don't know where you all are from. I know some of you came from far away. It may be illegal in your state, and it is still illegal by the federal government. So you can still be arrested in some states and probably put in jail. So make sure you know the law. But really what you want is that last bullet point, low THC, high CBD. So that's going to be very low on the intoxicating scale and theoretically high on the therapeutic window scale. Next slide, please. So absolutely do not smoke. Get medical authorization. And even in Washington State, if you live here, I would tell you to get an authorization because you don't want to be doing anything that your physician doesn't know about. There are some drug-drug interactions, not many, but you just don't want to be putting something in. Even if you're taking vitamins or something, you know, ginseng or something, tell your doctor about that. So get a medical authorization, get it on the record. Don't smoke. You shouldn't be smoking anything, and it's not necessary. A vaporizer is a good way to use cannabis. The cannabinoids will go into a hot mist at around 200 degrees Fahrenheit, and you just inhale sort of a fog. The advantage of a vaporizer is you get a rapid onset of effect. I've had a lot of older patients that never use cannabis, I mean in their 90s even, that can effectively use cannabis to relieve pain. I'll wrap up here quickly. You can get a topical effect too. There's CBD creams that you could rub on your feet. I've had very good success with that in people with CMT and other arthritic conditions. You don't have to be high. I always tell my patients that's not what we're talking about here. We're talking about getting an analgesic effect. So you don't need to be high to get pain relief. Start slow with a small amount and titrate and escalate the dose as needed. And the advantage, again, of the vaporizer is you can take 2 or 3 inhalations, wait 10 minutes, see what the effects are, do it in a controlled setting, not when you're going to be driving. Inhaled cannabis lasts about 3 to 4 hours. Now, you can use oral ingestion. That can be a little trickier, and the effects are a little more powerful, too, and they last longer. You can also get a concentrated sublingual tincture and just put a few drops under your tongue. That works pretty fast as well. Most of the places in Seattle and even in Spokane now, they have the actual ratio of cannabinoids on the bottle. They're pretty easy to separate out. You can use something called gas chromatography, and they split out based on their weights. So you can get like 5 milligrams THC, 10 milligrams CBD. That'd be a good one, right? High CBD, low THC. So next slide, please. Next slide, please. And I'll end with that. Thank you.
Thank you so much, Dr. Carter. That was incredibly informative.